name is Maciej Lesniak. I'm the chair of neurosurgery at Northwestern.
I'm Renus Lucas. I'm the associate chief of neuro-oncology at Northwestern. So today we're going to be talking a little bit about VHL or von Hippel-Lindau disease, which is a disorder that is managed via surgical intervention, radiation, and now systemic therapies.
One of the modalities, as Dr. Lucas just discussed, for the treatment of this is, of course, surgery. However, as I often say, we don't operate on scans, we operate on people. And there are plenty of patients with VHL who have lesions, if we will, associated with VHL, such as hemangioblastomas, that oftentimes can be followed conservatively unless they cause neurological changes or symptoms or wind up growing in a way that start making us concerned about the size of the lesion. The location, of course, is also important. Some of these can occur in the spinal cord, some in the brain. So again, we take into consideration the entire picture and the presentation of the patient, especially in cases where there are multiple lesions, to really try to optimize care that is patient-specific rather than imaging-based. My point being that just because you have some lesions in the brain or in the spinal cord doesn't always mean we act on it from a surgical, at least, standpoint right away. Sometimes we have to, but we're thoughtful and cautious about that as the ultimate approach. I think oftentimes patients present to either neurosurgery or neuro-oncology, and when there is a suspicion based on imaging findings that this could be a familial disorder like VHL, because you see multiple lesions consistent with the anatomy and the patient's history, I think it's really important to get your colleagues involved in the discussion and genetic screening of these patients, because in addition to their CNS manifestations, they can have other manifestations of the disease outside of the brain and spinal cord. And as a neurosurgeon, just being restricted to the CNS, I think it's important to have a comprehensive look at the patient and make sure that their disease outside of the central nervous system is actually not more prominent than what's happening in the CNS, especially if they're not symptomatic necessarily neurologically from what is going on. So this is where an expert like Dr. Lucas, who has tremendous experience in the field, comes in, because he has more of a comprehensive approach to looking at the patient systemically from head to toe, looking at all of the other organs, and then for us to work together on the CNS issues as they pertain to some of these tumors.
At Northwestern, we're lucky because we have a very comprehensive VHL program that spans the neurosciences, so neurosurgery, neuro-oncology, but all the other disciplines that are very actively involved. And I think for us here in the clinical neurosciences, we're embedded in the same clinic together, right? So we're seeing patients in the same place, and there's the ability to pull somebody in and say, hey, what do you think about this? Get curbside perspectives on it before developing and finalizing a plan.
I would also, I think, add to that we have a comprehensive infrastructure program that goes just beyond us, right? I think you mentioned this a little bit, whether it comes to neuropathology or our clinical trial work or our basic research that is starting to sort of look at this from a basic science perspective. So it's somewhat of a holistic, comprehensive approach where people come from all over the country to get second opinions and sometimes even validation of their original diagnosis that was done elsewhere, and people are not sure about what is going on with their clinical scenario.
And looking at it from a patient journey perspective, I would sort of divide it into three components. There is the original diagnostic evaluation, there's the subsequent screening, and then there's the therapeutic management. And some of these elements end up overlapping a little bit, so the screening and the therapeutic management. With regards to the diagnosis, if patients have a high suspicion for VHL, we'll typically have them meet with our cancer genetics counselors, who will guide them through that process and sort out whether that is truly the case or not. Once a diagnosis is established, then we make sure that they meet with all the appropriate subspecialists, and then the appropriate screening studies at the appropriate intervals are performed. And as Dr. Lesniak alluded to earlier, it makes, I think, probably his job a lot easier when he knows everything else is under control. All other elements are not active or are under adequate control before he embarks on neurosurgical intervention.
I think what you just mentioned is very important. VHL tends to be somewhat of a systemic disease, and the central nervous system is just one part of it. And so you can't have a very narrow or tunnel vision about that being the only thing that the patient is presenting with, without really considering all the other organs that can be affected. And maybe what's happening there is actually more at risk to the patient than the lesion that incidentally can be found in their brain or in their spinal cord.
And then once we do move into that therapeutic phase can be focused on the central nervous system. It can be focused on the systemic disease burden, renal cell cancer, etc. I think one of the exciting things in the recent past is the regulatory approval of a systemic therapy, meaning a pill that you can take to treat some of these manifestations of VHL, specifically the central nervous system hemangioblastomas, the renal cell cancer, and the pancreatic tumors. And what's kind of exciting for us is that this therapeutic modality seems to be effective in multiple locations in the same patient, which is exciting. So it can hopefully control disease in more than one place.